Hello and a very warm welcome to everyone joining this webinar on Fragile X syndrome and ASD, differential diagnosis with Dr Marcia Braden. My name is Liz Jewell and I work as the Family Support Counsellor with Fragile X Association. Dr Marcia Braden is a licensed psychologist with a clinical practice specialising in children and adolescents. She is a former teacher with experience teaching general and special education. She has written and published numerous articles related to education and behaviour management strategies, techniques and interventions. Dr Braden frequently consults with parents, therapists, educators and medical staff about effective treatments. She's respected for her work internationally. She has presented at numerous conferences and workshops about Fragile X syndrome, autism and other related disorders. And we feel very fortunate to have her present again for us today. Without further ado, I'm going to hand over the reins to Dr Marcia Braden to present on Fragile X syndrome and ASD.
I'm so excited to be here with you today, especially to discuss the topic of Fragile X syndrome and Autism Spectrum Disorder. We're talking today about both of those disorders and a differential diagnosis. We really need to take heed because there have been a lot of studies done about the comorbidity of Fragile X and Autism Spectrum Disorder. And I'm sure that many of you in the audience have had sort of some confusion about how can your child be both diagnosed with Fragile X and then with autism spectrum. And we're using ASD as the acronym now for Autism Spectrum Disorder. So when you hear me talk about ASD, that's what I mean. But to understand how that fits together and answer your question about how can my child have both, I want to help you with some determining factors that we have to understand in both disorders, and really how we diagnose them. It's a very different way of diagnosing. So I want to talk to you a little bit about the new Diagnostic and Statistical Manual. We call it the DSM, and this edition is 5, so the DSM-5. Now, it's really not that new because it came out in 2013, but it's still shaking up the world of autism because things changed pretty dramatically in that particular edition. Now, as the Diagnostic Manual not only has criteria for autism spectrum, but for all kinds of mental disorders. It just so happens that they really did look at autism spectrum pretty carefully to make some new criteria and to look at autism spectrum in a different way. So first they looked at consideration of intellectual levels, and that is something that was fairly new in the diagnostic criteria, that they really wanted to make sure that whatever we looked at behaviorally wasn't skewed simply by the intellectual levels of the individuals we were looking at. And that's important because, as you can see over on this next sort of piece of pie, it's characterized by a persistent impairment in social communication and social interaction in all areas of their world, so to speak, in all environments. And the important thing here is that those social challenges must exceed the level of intellectual development. And let me explain that a little bit. We know that people that are intellectually delayed and cognitively impaired, pretty significantly cognitively impaired, would in fact have social challenges. But we need these challenges to exceed what we would expect from an individual based on intellectual development. And then there has to be a presence of restricted patterns and sort of repetitive interests and patterns. And that was something that was a hallmark for diagnosing those with autism spectrum. So this is a really messy, crazy slide, but I lifted it from my diagnostic manual because I wanted you to understand how we now diagnose autism spectrum. So we're not going to read this. We're not going to go through it. I just want you to know that it basically just is this slide that I tried to simplify from the diagnostic manual. And so we do look at that persistent deficit in social communication. We also look at restrictive patterns of behavior and interests. And when we diagnose, we have to meet two of this list of four, at least two, of course, more if they do. And then we have to specify severity, which is a new thing. They didn't do that in the old DSM-4. So you have to look at the severity, and this dictates, very frankly, what kinds of services you're going to get for your child. So if the severity number is low, like a 1, that means that the person is not so impaired and wouldn't require as much support. But if it goes up to the 4, then you know that there's going to be, or 3, there's going to be more significant need for support. And this is an important one to see, and I don't expect you to read it. I'm going to tell you what it says. But it talks about that this ASD, all of these symptoms that we're looking at here, have had to occur in early development. So knowing that the person was diagnosed later in life, we want to look back on the developmental history of that individual. And it's really interesting because some of these people, let's say 30-year-olds that come into my office, and the parents say, we're looking at autism, and yet we've never considered him to be autistic. And yet when we go back and we look at all those symptoms in early stages and development, where there were lots of sensory issues going on, there were lots of issues with communication that have been resolved by the age 30, we can still, in fact, diagnose this person as having autism spectrum. And then we have to look at that particular symptom being impaired with that really is impaired enough to affect their social, their occupational, all of those kinds of areas of functioning, because it is a pretty significant diagnosis. So again, that's just looking at it from the manual. Now, I want to talk to you a little bit about where this came from, because we used to have the diagnostic manual. That was the 4th edition, and it had a very different look at autism, very different. And when this first came out, and you probably know this in Australia as well, there were a lot of people that were very upset with the new diagnostic manual and what it has done to autism spectrum. A lot of parents were very upset with this, and parents of individuals who had been diagnosed with autism spectrum for many years. And what happened was they looked at autistic disorder, Asperger's, and pervasive developmental disorder and lumped them all together in the 5 and defined it as a spectrum. So this is so interesting because at one point we had the classic autistic disorder, the person that checked off all the boxes was pretty significantly impaired. But then we had this subset, which was a group of people that were higher functioning. And in the old manual, it told you that Asperger's syndrome, in order to meet that criteria, many of the things that we see in those with the autistic disorder, but they had to have a normal IQ. And now this is now in the DSM-5 as autism spectrum disorder level 1. So a person who's pretty high functioning, who has the intellect to guide their path, so to speak, but still has some of those behaviors that define autism. They would be at a level 1, which means they'd get very little support. And then we used to have this pervasive developmental disorder, and a lot of people would call it, it's nonspecific. It's a PDD-NOS, and this was a global developmental disorder that a lot of people thought was a catch-all, and they really wanted to better define these individuals than to just lump them into this category of pervasive developmental disorder. So this is what's happened now, and I think it's finally at a point where people have learned to accept it. It does give more of a range in terms of our ability to diagnose autism spectrum, but it really did shake the world for a while, and people were pretty upset about the change. So let's look at causes, because I think this is what we really want to get into when we're looking at differential diagnosis. ASD is very complex. It has a certain set of behaviors that I just showed you, that long, busy sheet, but the etiology is not understood. So we've got these guys that have a diagnosis of ASD, but we don't know where it started, what the etiology, what really caused it. And there are a lot of theories. There are a lot of things that people will tell you cause autism, but really nothing has been done to define that systematically. Many of them have co-occurring conditions. So you look at intellectual disorders, you look at their communication deficits, you look at their social relationships and their restricted interests, and you can see how figuring out a cause based on all of those particular behaviors is difficult. The researchers have identified 100 high confidence risk genes, which I think is really very exciting, because for many of the families that I serve that have individual children that don't have Fragile X, but simply autism spectrum, they really are almost jealous of the work that we've done to determine exactly what gene causes Fragile X. And they've borrowed some of that research, which is great, to figure out some of these high confidence genes. And also, children with a sibling diagnosed with ASD, there's a higher risk that they'll have another child with ASD. And that's an interesting thing that Sally Ozanoff studied in 2011. And then individuals, of course, with Fragile X have a greater chance of having ASD. Now, this information, I should tell you, is taken from the National Fragile X Foundation's consensus paper, which the Clinical and Research Consortium has developed. And it's, if you just go to our National Fragile X Foundation website, you will see that there are a number of these consensus papers. And what that means is those of us who sit on the clinical committee have to look at this research, have to look at the papers, and we also contribute to it to see if it passes muster, so to speak. And we usually have lots of iterations so that we get a nice consensus paper that most of us can live with. And so this one is the one that's out, and it's been revised. This is the latest revision. And this is where I got a lot of this information. So it stands pretty solid. I contributed as well to this paper, and I think it's an important piece of literature for us to use when we talk about this subject area. So the causes, again, not real clear with ASD. Research is isolating that Fragile X gene, and that has really helped get closer to maybe something that causes autism spectrum. In other words, more of a genetic or a protein that they can identify. And that's really important because that's applied to finding a treatment for ASD. So if we can come closer, just as we have with Fragile X, to cause and what protein and what's absent and what's affecting their behavior, we'll come closer to matching up cause with the actual biology. So the same protein that's absent in Fragile X turns off protein synthesis and has implications for those with ASD and those with ASD that do not have Fragile X syndrome. So I feel proud about the fact that we're sharing some of our data and research to help this big group of people who have pumped lots of money into research and are still waiting to figure out some of the major causes. So again, looking at those proteins, I think that may be a place that we may go in the future with autism spectrum, and maybe they'll have their own set of proteins and they can take a look at that in terms of the cause. Fragile X, now we're going to compare and contrast. Fragile X clearly has one cause. And this is why it's so important to talk about this. As you heard earlier, the people that have autism spectrum just don't have a common single gene disorder. They don't have a common cause. They don't have a particular protein that affects their brain that's missing. In the case of Fragile X, we've got that all covered, don't we? We're way ahead of the game in that regard, and it's neat to know that we've worked so diligently to isolate that gene, and we really know what causes Fragile X. That expansion of the CGG repeat, and those of you in the audience that have heard me speak before know a great deal of this because I've talked about it many times. There's a site there if you want to look ahead and look it up, but I think many of you are probably experts in my audience on this particular area. So that sequential repeat of the CGG, if it's over 200, it's a full mutation, and it results in a loss of this encoded protein that affects brain development. So it is diagnosed, Fragile X, very clearly diagnosed by a DNA blood test. So it's simple. You know that you've got it. It's all scientifically based, and you can look everything up to prove that, in fact, you have that single gene disorder. And many people who are diagnosed with Fragile X also meet the behavioral criteria for ASD. Now, let me talk to you just a minute about that. Fragile X is something that we definitely can diagnose looking at blood tests, right? That's something that's just very obvious. However, we have ASD, which is diagnosed looking at behavioral checklists, so to speak. You got to have this, you've got to have this, you've got to have this. So, of course, the two could overlap because we have one genetic condition and then we have something else coming, some other checklist that we can use to determine autism spectrum. Just as many of your children with Fragile X may also have a diagnosis of ADHD. They may be attention deficit with hyperactivity. They also may have a diagnosis of bipolar depression. So many of the people with Fragile X will also have another diagnosis that's much different and tested differently than a DNA test. We estimate that roughly there's about 50% of the population of ASD that have Fragile X that have ASD. So about 50% of the males and 20% of the females. And again, this has been looked at many times. So you're going to see differences, maybe 10%, 5% differences, but it does come out to be roughly this number. So again, pretty good chance if your child has Fragile X that they may have some of the criteria to meet the criteria for ASD. There's going to be many, however, that have just a sprinkling, so to speak. In other words, they have a few of those behaviors that are akin to autism spectrum, but they don't meet the criteria for a full diagnosis. Again, this is what it looks like. It's very much a part of what we know about the brain and about this protein and the lack of it and what it does and some of the causes that we know about the connection. So again, you've seen this slide before, but I'm just giving you an update related to this is a very specific scientific sort of diagnosis. And again, we know what happens because the lack of that protein, it causes some issues with the dendrite spines and the density, so that the neurotransmission is really difficult and we don't see the full smooth process with a good pruning. And again, that's why this is the picture of those with Fragile X. This is a difficult sort of pathway for a message to get through. And that's why we have some things that go awry. So again, this was the first consensus paper, and then there was another one that we developed from it. And this one was the beginning stages of what we were looking at when we looked at the clinical and research consortium. So how does autism spectrum and Fragile X overlap? And then how are they different? And that's what this lecture is really going to be all about. You must understand that even though there are similarities, there are some specific distinctions when we decide what's appropriate for these individuals. And again, the paper that began in 2014 and then we piggybacked it, those people were very clear in terms of we have to do this. We have to talk about this because there is an important distinction. And a lot of the medical work, a lot of the therapeutic counseling and educational interventions have to really be looked at carefully because it's not a one size fits all. And we know this just from my lectures that I've given you and the webinars that we've done on education. We've looked at even a varying degree of effectiveness in those with Fragile X and looking at some of these things will work for them, some of these things will not work for them. And so again, we want to be very careful to note that it's very different when we're looking at individuals with Fragile X and autism spectrum. And it's even different when we're looking at an individual with Fragile X with comorbidity with autism spectrum and one person who has no Fragile X but strictly has autism spectrum. There's even a difference there. So I'm going to go through that with you so you can advocate very clearly related to what your child or your adult child needs. Now, what if they do have this dual diagnosis? In other words, they meet the criteria. Obviously, they've got the DNA and we know that they have Fragile X. They've had that testing. But then we're looking at the ASD diagnosis, meaning that they've met the diagnostic criteria. We've checked off enough of those behaviors to know that they, in fact, have Fragile X with ASD. Those individuals tend to have lower IQ scores. They tend to have lower adaptive skills, and that's pretty obvious. We could guess that because they have a double whammy in the regard of we have Fragile X, but then we've got some other interfering behaviors that really are difficult to deal with. Also, we see a lot more severe behavioral problems when we have a dual diagnosis. We have a lot more hyperactivity and anxiety, just everything that we know about those individuals with autism spectrum are there in those with Fragile X. Just remember that they're probably more affected if they do have a dual diagnosis. So one of the things that we've talked a great deal about is refining this diagnostic measure that we use to determine those individuals with Fragile X and whether or not to determine if those individuals with Fragile X have also autism spectrum. And we really aren't real close to that. It's something that we're working really hard to figure out. It's so different sometimes with those with Fragile X syndrome, and figuring out which ones of those symptoms really do in fact present. So we're looking at the educational, the vocational, the adaptive functioning, all of those areas to see how that looks with individuals who in fact have a dual diagnosis. There's similar but more severe challenges with those that have both. And we really want to get closer to making up a diagnostic measure that we can really determine what's best for these individuals who do have a dual diagnosis. Not just identifying them, but also making sure that we have those particular strategies in place for those individuals that are dual diagnosed. And then the individuals with Fragile X and autism spectrum have a higher frequency use of medication. Frankly, a lot of times the behavior management is very difficult without medication. And they have the likelihood of having delays, universal delays, like the toilet training, sometimes more seizures and sometimes sleep problems. So again, it's just a more compounded presentation. And we need to realize that when they have that dual diagnosis, they have a lot more challenges. This is a young man who has Fragile X, and I want to show you this video because it's going to point out what looks to be, if you didn't know he had Fragile X, you would say for sure he has autism just because of the way he's playing. So let's take a look at this. I cut out the background noise because it was pretty noisy, but you can see what he's doing with, we call those tinker toys, and he's smelling it, he's putting it at his mouth. He's really involved in the inanimate object as being his focus. And he's not really playing with it appropriately, like building with it or doing anything else. He's probably using it as a way to filter out some light. There's just a lot of things that he's doing with that particular toy that really is not a normal way of play. And again, that is just an individual who has both Fragile X, and really his behaviors look very much to be autistic. There are some similarities, and I want to go through these. And it's an interesting sort of thing to talk about, because when we just list the things that are similar, that they have in common, it's really important to look at what function these particular symptoms have in individuals with Fragile X and individuals with ASD without Fragile X. Because even though they look and they check off on the symptom list, there's a different function, and I'm going to explain that. So there's an unusual reaction to sensory input, both hypersensitive and hyposensitive, sound, touch, those kinds of things. And that's common in both populations. Also, some fascination with lights, moving objects, but in those with Fragile X, it's less, because in individuals who have autism spectrum, oftentimes they stimulate, self-stim on those particular things, whereas individuals with Fragile X is an annoyance. So that light or something that's flickering, remember we always tell people in an educational setting, be careful about the lighting because it's a distraction for them. With individuals with ASD, it's a fascination. It's a way to self-stim. So you can see the difference, even though it looks like there's a problem with it, right? And we can check that they have this fascination or they have this problem with the visual input. In those with autism spectrum, the function is more to self-stim on the lights. So it's a very interesting sort of similarity. Also, social interaction problems. Now, both populations show this. It's a big part of ASD as well as those with Fragile X. But there are some things about those social encounters that may look maladaptive in those with Fragile X. However, it's more about the anxiety that sets in to cause that social problem than it is with those with ASD. There's also communication and language delays in both populations, but in those with Fragile X, it's a wide range of language and speech aspects. In those with autism spectrum, it's mainly nonverbal and pragmatics, the use of language in social situations. In other words, being able to understand how language is used to communicate a thought. The poor eye contact, this is another big one, and I know you've all heard this many times, but I'm going to reiterate it. It improves oftentimes with those with Fragile X, but with individuals with autism spectrum, it's just a tried and true sort of characteristic. It doesn't really go away. You can sure teach them to look at you, and it's involved. That particular lesson is in many curriculum that we use with ASD. But those that are Fragile X, it really does improve as they get familiar with a person, as they trust a person, because we really think that it is related to their social anxiety issues. So of course, when they're meeting somebody, and I have a video clip of a guy that you'll see who's very social, wants to communicate, wants to have a conversation, but it's just painful to watch because his eyes are closed and he's trying really hard to be attentive and to communicate, but it's difficult for him. So again, once that eye contact is established, or you know someone better, they're going to start looking at you. You don't really teach it. They just have a relationship with you and they're not as anxious anymore. So another similarity, both populations, the seizures, higher proportion than to the general population. And this was studied by quite a few people. Both have difficulties with attention, activity level. Again, they may have hyperactivity, emotional behavioral regulation. This is a big one because we do see the sensory issues. We do see that in both populations. And that behavioral regulation is most likely related either to mood or the sensory input. And then also the nonverbal, having minimal language development, that persists. And oftentimes we say that the prognosis is guarded if individuals by age 5 are still nonverbal and not using any kind of communication system to communicate with others. Both Fragile X and ASD are typified by repetitive behaviors. They do meet that diagnostic criteria, but with Fragile X syndrome, it's very different. Again, the function of the hand flapping, the function of the repetitive behaviors is more related to excitement, sometimes some anxiety. So even though it might look like on a checklist that this guy with ASD meets this criteria, this person with Fragile X meets this criteria, the function is extremely different. And it really is very interesting, as far as I'm concerned, to make that distinction. So I'm going to show you a clip of a little guy who does the hand flapping, but you're going to see that he does it more because he's excited and happy than just to sort of self-stim on hand flapping like we often see in the autism population.
What's this? Oh, thank you. Thank you. Can you give me the boat? The big boat. Yeah, that's right. That was confusing. Where's he going? Ball. No. I like our ball.
So again, and she's doing a really nice job as a mom of saying you like the boat, and that's really what it was all about. He was excited. He was very excited, and it was something that has a function to it that is not just simply to engage in repetitive behavior. So again, yeah, if we say they meet that, you have to check that off because they do the hand flapping or they do some general sort of perseverating and repetitive behaviors. But the function is very different for those with Fragile X than it is with autism spectrum. And the reason this is important now, and I'm going to get to it, is that treatment is varied with these two populations. The treatment is varied because the function is different. So this is a guy with Fragile X who has a really hard time giving eye contact, and I see him online. He was at my office one day just so I could do some testing, but usually see him online, and it's very hard for him to communicate and look at the other people in the group because eye contact is painful for him. So again, the nature is different. We have another different sort of function, don't we? Because individuals with Fragile X avoid the eye contact just as those with autism spectrum, but they look away from people and they can't really give you the eye contact because of the social emotional element that brings to them. Not that they just don't care, and I'm saying that loosely in terms of the autism spectrum population, but their interaction with people is much more limited, and they just simply ignore others. And that's why they'd rather be left to their own devices, and they'd rather be doing some things in self-stimming than being around people. And so that's where they then get that sort of symptom that they don't offer eye contact. So again, this is an individual with Fragile X. You can see the difference. He's having a hard time. He couldn't look at the camera when I asked him if I could take his picture. Social anxiety is what it's all about, frankly, and that's why there's a difference here. Yeah, they have a problem with eye contact, as do others that have autism spectrum. However, it's because of social anxiety. These individuals try really hard to have that visual interaction with you, but it's so difficult for them because it's related to their social anxiety. So individuals with ASD make very little eye contact for other reasons. They have a lack of recognition sometimes in terms of who's out there and who that person is. Eye gaze is a source of social information or interaction, and they really tend not to be interested in that at all. And then interest in socializing is higher for those with Fragile X than they are with autism spectrum. And there was a really interesting study that was done that I didn't note here, but remembering a while ago when some of the people in Denver were looking at early diagnosis for individuals with Fragile X and also autism spectrum. And it was interesting to note that many of the babies with autism spectrum at a young age didn't recognize their mom, their parent, didn't have any different discrimination of mom versus a stranger. And those with Fragile X did. And so I think that kind of tells you what that interaction looks like and that relationship building looks like early on with individuals with Fragile X, that they really want to have that association or that relationship. But what happens is there's so much social anxiety that gets in the way that then it doesn't happen. And it looks to you like they just can't offer eye contact. Individuals with Fragile X lack social initiation. It reflects in language delays, intellectual disabilities, and in general, there's a lot of social anxiety there. In contrast, the lack of social initiation in ASD, including individuals that have a dual diagnosis, are defined based on reduced interest in people, basically, in social interactions. And a lot of individuals with ASD don't have much interest in other people, in social interaction, any kind of social behavior. People with ASD have higher levels of motor coordination, so there's a difference there. However, that motor imitation skill is better in Fragile X, and imitation in general is better with Fragile X. That's why we preach all the time about how our children with Fragile X syndrome must be included with typical neurotypical peers because of their ability to imitate. Now, this is talking specifically about motor imitation, but we can look at how that does enhance any social interaction because they can imitate what they see others doing, and they can really normalize their own behavior because of that. Individuals with ASD likely to show higher expressive language skills relative to receptive language, while, and this is interesting, those with Fragile X show a higher receptive language and less expressive. And Abaduto just studied this and has continued to study it. It's fascinating to me because what they're saying here is that the people with ASD can express themselves, but they don't understand what you're asking them to do oftentimes. So they're a little higher expressive language, but they don't always understand the reception. Fragile X individuals, and this is why we talk a lot about watch what you say in front of them, because they truly do understand receptively what's going on. They just have a harder time now speaking and expressing what their thoughts are. And even when they're higher functioning, this becomes extremely difficult, very difficult to disclose their feelings without lots of good prompting. Differences again, difficulties with attention, activity level, and emotion. Oftentimes we see that in the individuals with ASD. Other behavioral issues like aggression and noncompliance and self-injury seems to be more prevalent in those with ASD. They have been reported to have more sleep problems than our people with Fragile X. And I know that's hard to believe sometimes because a lot of individuals with Fragile X do in fact have the sleep problems, but this is just what they've noticed through their research. Unusual reaction to sensory input and sensory seeking. And so again, even though some of our guys with Fragile X meet the diagnostic criteria for ASD, those with ASD would have more reaction to sensory input. And the sequential processing is typically harder for individuals with Fragile X than with ASD. So again, we know that's a hard one because the hard wiring for those with Fragile X is such that they're not sequential processors. However, those with ASD are, and I've seen individuals with ASD follow instructions and put things together, even if it's picture to picture, they can actually put things together manually in a way that I don't often see in those with Fragile X syndrome. So another difference is this transition making, and we've talked about this before. They definitely display a strong reaction to changes in the environment, more so than their counterparts that are ASD. People with autism demonstrate a need to keep things the same, but it's not related to a change in the environment. So they like things lined up. Those are the kids that play with their toys and line them up and keep things in certain places and like things a certain way, but it doesn't have to do necessarily with a routine change. So you can see this guy is making his transition into my office. I'm going to put that hand on. Give it to her. So he has to get rid of his device. So now he's going into the room, and we've worked really hard to make this happen. And now he has tokens that he can put down because he came in and he's working basically to go see his mom again. So this is how we override that aversion to a transition or a change, because he's not used to coming into my office and transitioning in. This is early on in our therapy. And again, this is really important because those transitions with individuals with Fragile X have to be really targeted, and we have to have certain interventions that work with them. So let's look at the differences again. We know that this is a syndrome. And anytime you have a syndrome, it means that you actually have physical features. So those of you that are familiar with Down syndrome know that there are certain physical features that those with Down syndrome meet. And that's the same case with those with Fragile X. A lot of times we have a long forehead, a long face, large ears. Now these guys, every single one of them has Fragile X. And I like this picture because it can show you the variation. For example, this guy definitely has the long face and the forehead. This guy doesn't so much have the long face. He has the bigger ears. This guy has the bigger ears. And again, this guy doesn't have the long face. So this is just part of the phenotype that we describe, but not every single person meets all of the physical phenotype. This guy does have the long face. And we think that, well, at least what we've observed is that early on, when the kids are a little bit younger, sometimes they don't show the long forehead or the long head, but it develops later on as they develop. Also, there's a lot of different things going on with this population, this hyperextendable joints. You can see this right here when we look at her foot. This is definitely there. She is double jointed, and that is something that comes through the gene. Low muscle tone, which does cause some major issues when we're looking at trying to get them placed to work somewhere or to do something that might have physical component. It's hard for them. Malocclusion in their mouth, mitral valve prolapse with their heart, and then macroorchidism with the guys, which is large testes. Now, people with autism spectrum, we don't have this physical phenotype. We don't have this defined because it doesn't come from a single gene, which we see in Fragile X. The differences, again, avoiding the eye contact. This is really difficult. Again, people with Fragile X can read a room. They really do study who's out there, what's going on, and you'll see them looking around. And the minute anybody looks at them, they're going to look down, right? Because they don't want to have that eye contact. In contrast, we have individuals with autism who would rather just play with toys or maybe even in an inappropriate way and have no idea what's going on in the room and really aren't affected by people asking them to look at them. They may mechanically do it, but it doesn't have the kind of adverse effect that it does with those with Fragile X. Again, this is so important because this little guy is so cute because he's imitating his teacher beautifully while they're singing. Imitation is so important, that motor imitation, beautiful with Fragile X, a lot more profound in those individuals with Fragile X. And imitation is a strength for them. It's the hallmark, isn't it? It's the foundings, what we need for learning. So that's the important thing about those with Fragile X. They can learn through imitation. That's probably the best way for them to learn. And that's why we advocate video modeling. We advocate watching movies and clips and cartoons to learn certain things, certain behaviors, to learn skills even. It's a really effective way of teaching them because it is so clearly a strength for them, whereas the people with ASD, really not so much unless they have that co-occurring diagnosis. Again, genetic, you inherit the gene from a parent. Girls can get it from either their mom or their dad. Boys can only inherit it from their mother. And the fact that the family's impacted by the gene creates additional dynamics that we don't have in a family that has individuals or children with ASD. Even when they maybe have more than one, it doesn't have the same dynamic because it doesn't have a genetic component to it. So let me show you a presentation of the two individuals with Fragile X and Autism Spectrum. Those of you maybe have seen Jerry before. He is autistic and he's going to tell you about having autism.
Would you tell us a little bit about your early education?
I would like to. Back in the first grade, I was bullied by a lot of kids. I guess they were jealous because of my condition. Thought I was some kind of wildcat, scavenging the whole class, being very disruptive. The teacher had to put me in an isolated place, like in a separate room, curtain over me, and I do really remember that. Then I had to be taken out of the school for, don't remember the name of it, but I was taken out before. Also, I was left at school before because of my silliness, excessive silliness.
What was your silliness? What'd you do?
I would like scream out of some weird tones of whatever kind of sounds I made. Don't remember though, but I was very disruptive, being kind of.
So this is really an interesting interview because what I want you to look at was the eye contact, and he really was good at that. He also had some sort of that I've noticed in many people with ASD. Their verbal skills are different in that their intonation patterns are different. Sometimes they end a sentence with like it was and you see this with him. He definitely is very introspective. Now, at this point, that's probably been 20 years ago when he was in elementary school, but he could give us some pretty good definition of what was going on. Now, some of this I'm sure was discussed with the uncle that he lives with now and maybe reiterated, but I do think that he does a really good job of sequentially looking at what that looked like and what was going on and why he was different and why he was punished. Now I want to show you an interview I had with another individual with Fragile X, much different in that you can see very animated, very social, but having a horrible time with eye contact.
So what do you do over there?
We just work about half hour.
Do you put things out on the shelves or do you greet people? What part do you do?
We just take all the trash outside.
Okay, that's what I was looking for. Good job. So you're the trash guys over there. Yep, I got a lot of guys that work at Walmart. I've got one guy that comes to see me that has Fragile X that's a greeter at Walmart. And he gives everybody, you know, when you come in, how you give them their cart and you say, hi, have a nice day.
Yeah.
That works out really well with him. He really likes that. And people love him. Oh, because he's so nice. That would be a great job for you, I think, wouldn't it?
Oh, yeah.
Okay. So
I might be interested in knowing what you used to do.
I would love to
in
know.
high school when
What
you
did
worked
you
at
do?
Gordon Lane.
What did you do over there now?
I did laundry over there.
Did you? Now, what is that place?
It's all the people who get sick.
Oh, it's like a nursing home?
Oh, it's nice.
So you can see that it's harder to understand him because his articulation isn't as good. We know because we have low muscle tone. Those of us, those who have Fragile X syndrome, have low muscle tone in our mouth. And so articulation is difficult. But I want you to see the difference in terms of the social relationship. He really wanted to respond. He wanted to have a social interaction with me, and he made that happen. And so there's a real difference there in terms of eye contact, social relationships. On the one hand, Jerry was the person with autism, very serious and telling his story in a very serious manner, like it was his job to do. And the guy with Fragile X really had a relationship with me. And I didn't know him that well, but he really wanted to interact. He was smiling. He seemed happy. He wanted to please. Very different sort of presentation. So why is this so important? This is probably the most important part of my webinar today, because an accurate and early diagnosis can really do important things for individuals with Fragile X and autism spectrum. They may need certain therapies that support the essentials of what's going on with them at an early age. And the quicker we can make those diagnoses, the better. It's easier with ASD because it's a checklist of behaviors. In the case of those with Fragile X, we have to do the DNA. We have to take that. Sometimes insurance will pay for it, sometimes not. Sometimes it takes a little bit longer, but it's so important to get an accurate and early diagnosis because it will definitely prompt that referral to get help. The treatment and intervention recommendations for individuals with Fragile X who also meet ASD, that treatment is interesting because we will usually follow that we use with those with ASD, but we have to rock the boat a little bit with that. In other words, those of you that know about applied behavioral analysis, I'll talk about that in a minute. That's the gold standard for those with ASD. However, we really have to massage that carefully when we're looking at using it with individuals with Fragile X, even if they do have a dual diagnosis. There's been a lot out there written about the treatment and recommendations for individuals with autism spectrum who do not also have a diagnosis of Fragile X. And those of you that are familiar with those particular groups for ASD, they are powerful. They're doing a wonderful job. They do a lot to advocate for that population. And I think we're running along in kind of a close second at this point because I think because it's a more rare disease, so to speak, with Fragile X, we have to meet a criteria that is scientific and medical versus the people that are diagnosed with ASD. It's a checklist. And there can be some mistakes in that diagnosis. I can see people oftentimes that come in and say, we'd really like to get a diagnosis of ASD because if we do, we will be able to procure more funds for our son. And it really is important for us to get as much funding as possible. And of course, that's just an unethical sort of thing for me to do, for sure. Similarly, there are a lot of books that are written about Fragile X syndrome, but not as many as there are out there for ASD. So our job is to look at both of the diagnoses and then determine what part of the treatment is going to work best for our individual cases. This is a good example of what I'm talking about in terms of some of the methodology that's out there for individuals with autism spectrum and how we have to massage it a little bit to do it differently. So this top one is an ABA therapist who is working with an individual with ASD, no Fragile X.
No, where's that? There you go. Where's F? Yeah, nice job. Where's F? Good looking at me, Joshua. Where's F? Nice, buddy. Very smart. One more. Show me F. Way to go, dude. Great. Can you read? Good try. Book. Book. Nice reading. Where's book? Much better. Can you show me book? Yeah, good job. Can you read?
This little guy he's nonverbal, so he's signing, and that's what he does to read. He'll read the word and then he'll make the sign. But you can see this is mass trialing. That's a part of ABA methodology, which is very effective with individuals with autism spectrum. You can see that it's paced very quickly. There's a lot of responses per minute. That's the whole idea, is to kind of pace that, overlearn it, do a lot of trials so that it's set. It's a direct teaching format, so that's how they teach individuals with autism spectrum, and this has been very well researched. So let's look at kind of something a little bit similar. This little girl below has Fragile X, and we are using more pictures, and we're using pictures to read, and I'm working with her in a sort of a less direct way.
That's K. The guy is pain. Yeah. So here we have this picture right here, or this word right here. No. Where would that go? Yeah, sure would. What about this one? What does that say? What does it say again? Oh, yeah, there's cub. Okay, what about this? Where can you find that one? Hut. That's a well. Is there a hut around here somewhere? Yeah, there's a hut. Okay. And what about this one? What about this one right here? It says, what does it say? Dart. Dart. Do you know a dart? What does a dart look like? You throw it in. Yeah, put it there. Good job.
So I'm trying to be indirect with her because she has so much anxiety and performance anxiety that if I use the methodology above, I'm afraid she would have caved. And that's why we have to be very careful when we're looking at different methodology for these two populations.
No.
Again, some curricula actually really teaches eye contact. So look at me, and that's what this one is all about down here. This is a little girl with autism, and sometimes even holding a face toward you to look at you is a way that they train this particular behavior. People with ASD, you can see what's going on here. This is a social situation where Kyle is shaking Jamal's hand, but the problem is he can't look at him, and we've got to train that in so that when he does have a social encounter where he needs to shake someone's hand, he is looking at them. So again, we don't force the eye contact, but we put it into the context with those with Fragile X that is a social context that makes sense for them to make eye contact. Now, we might ask him to look at the top of the head here. We might allow him to wear sunglasses inside to start the process. There's got to be a way to teach this in a social context. Sometimes we've borrowed a lot from people with ASD and all of the people that have developed that methodology. A lot of what's out online is really developed by teachers of individuals with ASD. A lot of our picture schedules and those kinds of things came from that particular group. So again, that is really important that we can borrow from those with autism spectrum to help our individuals with Fragile X, because we know they learn best with pictures. We know that sequencing is hard for them so that they can see the entire gestalt. I wake up and I get on the bus, but this is what the middle looks like. That is really effective with individuals with Fragile X. Clinicians must appreciate the similarities as well as the differences. So if we understand the treatment strategies for those with ASD, we can advance the treatment and educational plans that are appropriate for those with Fragile X. Again, this is something that I developed in terms of an overlay, but there were a lot of programs previous to this or prior to this that used the dot math and those kinds of things. So again, I just took that and made it more functional with pennies. But again, we need to understand that a lot of those strategies are really appropriate for individuals with Fragile X. And again, we need to remember that support workers, teachers, oftentimes I hear, yeah, I haven't ever had a student with Fragile X or a client with Fragile X, but I've dealt with so many people that have autism spectrum that I know I can handle it. It'll be very similar. And that's not always true. So I want to make sure that I make it clear that just because you maybe something about autism spectrum or you've been successful with individuals with autism spectrum, that doesn't necessarily mean that it's going to be appropriate, or some of the strategies that you use will transfer over to those with Fragile X syndrome. For example, I want to show you, this is an adapted ABA methodology. Again, this is something that has been researched, very scientifically sound for individuals who have ASD, very much, but not so much with individuals who have ASD and Fragile X, or have Fragile X only without ASD. So I'm doing sort of the setup like a lot of people would who understand ABA, applied behavioral analysis, but we're again massaging it and making it a little bit less direct in this particular video. We have these sheets out. These are called placemats. What does this say? What does this say?
Talk about.
And what does this say?
Grilled chicken.
No, look again.
Pizza pie.
Pizza Hut. Pizza pie. So where does this go?
Well, here.
It sure does. Because that's Pizza Hut, right?
Yes.
How about this one?
This one.
What is that?
Walmart.
It sure is. How about this one? Let me think. Let me try to trick you. So I'm trying to make it a little bit of a game that keeps the attention. Also, it's important to note these particular pictures are high interest for this little guy. And that's really the point of this video. When you're doing just an isolated teaching of a letter or teaching of a sound or a number without a context, it doesn't stick with individuals with Fragile X. When you're teaching something that isn't interesting, has a high interest content, you're going to have a harder time of getting results. And so again, that's why it takes a little different. We can use the same sort of methodology, but we have to use different materials that are of higher interest. And we also have to massage it into a game or something that is less direct, because we know they shut down, they get anxious, and we will not get the results that we want. Excellent work, mister. Again, critical for teachers, therapists, anybody involved with those with Fragile X, not to lump them together with those that have ASD, because it just isn't true, it isn't effective, it's not always the best treatment. So Fragile X is best treated utilizing what we know specifically about that condition. We know they're anxious. We know that they're not sequential learners. We know that there's some issues with memory. So we have to remember those things because we've studied those very carefully, and we've studied those in a way that's been very scientific, because remember, we have a single gene. So we can isolate and really look at that information and make it richer than we can for individuals who have ASD that have many reasons and have many causes for their particular disability. So many programs use direct instruction, as we talked about, applied behavioral analysis with students that have autism, and they often use it with people with Fragile X, but it's very important to modify those techniques. We really have to look at more research to define and refine ASD, the diagnostic measures we use for individuals who have a dual diagnosis. And it's important because that will dictate what we do in educational and vocational settings. Adaptive functioning, all kinds of things are so important because those challenges are going to be there. And when we have individuals who have a dual diagnosis, we know that the challenges are going to be even greater. We've got to get closer to defining those diagnostic measures to know exactly, not only do they meet the criteria for ASD and have Fragile X, but what are the particulars related to this individual who has a dual diagnosis? What can we do that's going to make things more efficient? Again, the research is telling us there's a difference in social development. The features in autism spectrum are a core part of the Fragile X phenotype, and it's an important the diagnosis is important because it overlaps, but we have to look at how we measure that and how we treat it. And we need more clinical trials to make that happen. The current measures that we're using in social development for Fragile X really include that parent report, questionnaires, subjective scores that aren't really derived from direct interaction with the patient. And this has been, I think, one of the biggest frustrations for all of us in the field, because we really want to see that research that's based on observations. And a lot of these checklists are really good and important, but we'd love to get closer to really honing in and defining what it is that we want to target when we have treatment with these individuals. We came up with a really good paper, I think, and I want to share this with you before we finish today, which was something different. We know that a lot of people use the Autism Diagnostic Observation Schedule. It's called the ADOS. It's a standardized series of interactions and also observations of individuals to diagnose ASD. We look at some of those symptoms that we talked about that are on that checklist for the DSM-5, but then we also watch how they interact with different materials, stimuli, etc., and we code it accordingly. The problem is it takes a lot of training. It's very expensive to administer because it's lengthy, and it's not designed to measure change over time. So we get an original diagnosis, we observe, it's very good. I'm not trying to tell you that it's not. It's really debilitating in some ways because of the fact that it takes so much time and it's very difficult for people to administer. They have to have a lot of training. If we can identify a more efficient measure that can evaluate social interaction, monitor change over time, look at, okay, this intervention in my post-testing, this intervention looked really good. This kid is doing so much better with social interaction. What did we use to get there? And then we can start looking at what we can use generally in the population of those with Fragile X to improve the social interaction. So a bunch of us got together and wrote a grant, and we wrote a paper. We did a lot of research around what is called the ASEP-3. This is the Autism Screening Instrument for Educational Planning. But we only used one of the subtests of this. This is another one of those that's observational and is statistically designed to measure how individuals interact with stimuli under different conditions. One condition is we play with them or we interact with them if they're older. The next condition is passive. We get passive and we're not talking to them and we lean back here. And the third one is giving them direct instruction. And then we also score their interaction in those particular conditions. So this is the research that we did. And these are the people that were involved in the research. What we did is we looked at this ASEP-3, and it's a 15-minute sort of play-based session. If they're older, we did interaction with devices, with magazines, with sports cards, with different things like that. So we used it for individuals who were even older than 13. And we basically just took the raw scores, calculated a percentage, and that became the values that indicated that there were more symptoms in that particular domain. So anyway, we adapted the materials. We looked at kids over time, adults over time, and we really had to get the training to be consistent because we were looking at behaviors and we had to compare what we saw and what I saw and what somebody else saw. So again, a lot of videos back and forth, a lot of training, a lot of looking at a video together and scoring to see if we thought that was interaction or not. And it was really fascinating what happened. It was a great study. This is what it looked like. It's a hard thing to look at, but I wanted to show you what it looks like. So here's the interaction under active modeling, under passive, and under direct cues, and we would just score it accordingly. Constructive play, if that's what the guy was doing, if they didn't respond at all, and if they got aggressive, if they threw a toy or did something. So that's how we rated it. And then we added up the totals down below, and we looked at the percentages to see under what conditions we got the best interaction. And here's just to show you how this works. I think you're going to really find this fascinating as we did. So this is a guy that's in my practice. That's why I can show you this video from the study. And he's interacting with this particular person in the active modeling and the passive condition. So we start out with a puzzle.
Let's see. I'm gonna
start with the edge.
Yep, I'm gonna find the corner pieces. Let's try to clear this table off a little bit.
It's kind of doing that.
Yeah. Let's see, there's one corner piece.
So we're watching to see if he interacts and if he talks to her. And they're playing or they're putting the puzzle together, and that's how we score it every 10 seconds.
That's a good idea. Here, I'm just gonna move these over here.
We want to do it on the...
All these over here. Let's see here. I'm gonna find... There's another corner piece.
Nope, it doesn't fit.
No.
So he's interacting and he seems happy and relaxed. There's a lot of data that we're gathering right now because he is interacting. He's verbal, he's appropriate, he's engaged in the activity.
You're good at this, huh?
Mm-hmm.
Great. I'm gonna flip all over. That is great. You were doing an awesome job. You weren't kidding when you said you were a pro. Okay, here we go.
Look, ta-da!
Over. Yeah, wow, awesome. Here, I bet this goes somewhere there. I'm gonna put that right there. Nice.
What is it?
Now you're gonna watch her get passive. That's the next condition. And so she's gonna pull away from the activity. She's gonna drop her head and she's gonna get real quiet. I want you to watch his reaction to that.
You're doing great. I'm gonna find where this one goes. Let's see. Let's see if I can find another corner that would match.
This is breaking.
Oh, I need to tape that one. Let's leave it out. Oh, I found that corner piece.
Do you have any tape?
I can get some later. I don't have any on me. No. I'm gonna see if there's anything fun to color in here. I'm just gonna take a break from the puzzle for a second.
I'm gonna finish it.
Okay, let's see here. I've got some NFL coloring pages. No, I like the Broncos.
Okay, she's passive now.
We missed our puzzle pieces.
Thank you.
You can start to see what's happening with him, with the guy with Fragile X.
This one?
He's talking more, he's referencing her more, he's looking at her more,
Look, ta-da!
and he's starting to get a little anxious.
Yes.
And now he's listening to the tape. He wasn't before because this gives her the idea of when we score.
Saying yes.
And he's getting pretty uncomfortable here.
Oh, wow, that's awesome. You're doing such a great job.
Should we say yes?
You helped me out with my corner.
Yes.
Okay, I'm gonna color.
We are ready.
I think they're purple.
So you can see the difference. When she's passive, he really is anxious. He's concerned. He's talking more. He's trying to engage her. The guy on the tape is bugging him more because of his anxiety level. And this is something that we found with many of the individuals that we looked at. It's fascinating to me because it really does tell us something about the Fragile X individuals and their social interaction, their real need to be social and to be connected with people. So the results were simple. Those individuals that had ASD and they were dual diagnosed and Fragile X, there was an even split of a noticeable difference when we switched from the into the passive phase, okay, an even split, okay? And then also they didn't have the emotional reaction to the passive phase as did the other ones. When they didn't have autism spectrum, but strictly Fragile X, almost all noticed the switch to the passive. Most did not have an emotional reaction to the passive phrase, and there was an even split among those without ASD. So it tells you that there was a noticeable difference. They really noticed the switch to the passive, right? And they also had that sort of emotional reaction to the passive phrase that was very different than the others who really didn't noticed it right away. So this is fascinating to me to see the difference in those individuals who did not meet the autism spectrum diagnosis and those that did. You can see that there was a real difference there, right, in noticing that passive phrase and what was going on. So again, just something to think about. We would like to replicate this study to bring it forward because it tells us a lot about treatment. Again, we've gone through pretty much the summary. I think you understand what I'm talking about, that there was indeed a difference in those individuals who had a dual diagnosis and who did not. And we really want to look at those ASEP scores in the future to see if there's a way that we can expand that sample size and make better conclusions. So to finish up, I want to talk about the conclusions overall, not just of the study, but I really want to talk about the conclusions of this particular webinar. We have to be clear that it's important to understand the differences between Fragile X and ASD, because treatment strategies and intervention will be different. We have to be more targeted and specific to those individuals who have a dual diagnosis. We have to be more specific with individuals with Fragile X in terms of treatment. And we have to take into consideration their presentation. These individuals with Fragile X do not respond as well to direct instruction. They tend to have some anxiety around that. So it's really important for us not to just lump this all together and with autism spectrum. So it's going to work with those with Fragile X. It doesn't work that way. And it's really important for you all to understand that. And when you're advocating for your child, or you're working with an individual in a work setting, or you're a support worker, it's critical for you to understand that these individuals have lots of anxiety around social interaction, around changes in routine, around really the video modeling, the imitation, those kinds of things. They need that intervention strategy to work more effectively. We have to understand the similarities and differences so we best serve each population, and we serve those that have a dual diagnosis in a different way than we would with those that didn't. And it's also important for parents to adjust your parenting styles when we consider Fragile X and those affected with ASD. It will be a different outcome every single time. So I hope this has clarified the distinction between Fragile X and autism spectrum. I hope that you understand there are some individuals that do meet the diagnostic criteria for ASD, along with having their DNA studied and knowing that they have the gene, their Fragile X. I hope that has been helpful to you in terms of looking at those similarities and differences and moving ahead to serve all populations with more efficiency.